Ventricular arrhythmias originate from abnormal electrical activity within the ventricles. They range from benign premature beats to life-threatening rhythms like VT or VF. Premature ventricular contractions are single early ventricular beats that may be unifocal or multifocal. They can appear as isolated events, couplets, or frequent ectopy. Ventricular tachycardia is defined as 3 or more consecutive ventricular beats above 100 beats per minute. It may be non-sustained under 30 seconds or sustained beyond that, requiring intervention. Monomorphic VT shows identical QRS complexes beat to beat, while polymorphic VT shows changing morphology. Torsades de pointe is associated with prolonged QT interval. Ventricular fibrillation produces chaotic electrical activity with no organized QRS complexes. It is immediately life-threatening and leads to sudden cardiac arrest. Idioventricular rhythms occur when ventricular escape pacemakers take over, usually at rates below 100 beats per minute. Accelerated idioventricular rhythm is often seen after myocardial infarction. Evaluation begins with a 12-lead electrocardiogram to identify morphology and origin. Echocardiography and cardiac magnetic resonance imaging assess structural heart disease and scar. Risk stratification includes symptoms like exertional syncope, family history of sudden cardiac death, and medication review for QT prolonging agents. These factors guide prognosis. Management depends on severity and underlying substrate. Beta blockers are first line for many ventricular arrhythmias, while amiodarone is used in structural heart disease. Potassium channel blockers like sotalol and dofetilide carry torsades risk due to QT prolongation. Sodium channel blockers can be effective but may be proarrhythmic. Implantable cardioverter defibrillators terminate VT and VF using shocks or anti-tachycardia pacing. They significantly reduce mortality in high-risk patients. Catheter ablation targets a arrhythmogenic substrate using radiofrequency energy. Success is highest in idiopathic ventricular tachycardia and scar-related circuits. Idiopathic ventricular arrhythmias often occur in structurally normal hearts and are usually benign. Structural heart disease with ventricular tachycardia carries high sudden death risk. Key takeaway is that QRS morphology and clinical context determine diagnosis and risk. Ventricular arrhythmias range from benign ectopy to immediately fatal fibrillation.